Hi, my name is Nick Smith and I'm Head of Clinical Skills for Undergraduate Medical Education at Central Manchester University Hospitals. What we're going to look at today is an introduction to peripheral IV cannulation. This is a generic lecture to give you the principles behind what we do and why we do it when performing this skill. The reason it's generic rather than specific to the trust is that there's no one way of doing this skill. Practice and policy will vary with time, hospital policy, and even with different areas of the hospital and the equipment used. What is important, however, is that you follow the guidelines or policies in the area you're working when performing this procedure in clinical practice. A cannula is a small plastic tube which is inserted into and left in a vein using a needle and is used for delivering intravenous fluids and drugs to patients. It composes of the cannula itself, which has a cover over the needle and often has wings to the side to help secure it. There's a needle which fits inside the cannula that is used to introduce the cannula and is then removed. There's a bung which is fitted onto the end of the cannula after it's inserted to stop blood leaking out, but we're going to show you how to cap it off using a separate needleless bung system called an octopus, which is an extension line and is commonly used in practice. Cannulas come in a large variety of sizes. Rather stupidly, it uses a system of sizes where the smaller the number, the larger the size of the cannula. So a 16 gauge is actually bigger than a 22 gauge. You'll find people tend to refer to them by colour sometimes rather than size. Orange is the largest size, followed by grey, green, pink, and blue is the smallest adult size that we practically use. The larger sizes tend to be used if we're likely to need large volumes of IV fluids giving fast, such as trauma, sepsis or surgery. When the needle tip inside the cannula pierces the vein, blood will flow down the hollow needle and appear in the flash chamber. This is known as a primary flashback and indicates that we've entered the vein. Pulling the needle back slightly will cause the blood to flow down the cannula around the outside of the needle and into a second chamber. This is known as the secondary flashback. Lowering the angle of the cannula will allow it to pass smoothly into the vein. Holding the needle still, we can advance the cannula body into the vein all the way and then release the tourniquet. Pressing on the vein at the tip of the cannula will prevent blood from flowing out the end of the cannula when you remove the needle from it. Removing the needle just leaves the cannula in place, which then needs the octopus attaching and then flushing through with saline to prevent the blood from clotting in the cannula. Complications of cannulation include missing completely. I won't recommend more than 2 attempts at inserting a cannula as a medical student, as both your confidence and the confidence of the patient in you will begin to dwindle. Blowing the vein is another risk, where you go through the other side of the vein, usually given away by a bubble of blood which appears under the skin. A more serious complication is infection of the site, known as phlebitis. We do the best we can to limit the risk of this by using a technique called ANTT, or aseptic non-touch technique, more of which in a moment. But effectively it means we don't handle any part of the device that we're going to stick into the patient. We also review cannulas after 72 hours and consider removing or replacing them. We use a special occlusive dressing on the cannula which allows us to observe the puncture site closely. We use other devices like the octopus, which limits the movement of the cannula and therefore also reduces the risk. Mention ANTT to some doctors and they'll roll their eyes, but that's usually because they've come across somebody who may have been a little bit overzealous about it. The principles behind it are actually very sound. There are certain parts on devices that will be inserted into the patient's bloodstream. There will be parts on other devices that will be attached to these parts. If these parts get contaminated, then there is a higher risk of the patient developing an infection. Therefore, don't touch these parts and don't let anything else that's not sterile touch them. It's all fairly logical. These parts are known as key parts, and on the cannula they would be the length of the cannula up to the main body and the needle, as both will be entering the vein directly. The flushing port, as anything injected in here will be pushed into the patient's bloodstream. The end of the cannula and the inside of the white bung which connects to the cannula. All of these are covered when you take the cannula out of the packaging. For the flush, it will be the ports where the needle and the syringe meet, and the needle itself once the cover is removed. Once the top is broken off the saline, it's also the inside of the saline vial. On the octopus, it's the two flushing ports which are not protected, and the tip where it comes into contact with the cannula, which is already protected by a cover when you remove it from the packaging. Before inserting the cannula, as with anything to do with patients, we should introduce ourselves, explain who we are and what we'd like to do and why we need to do it, the risks versus the benefits, and gain their verbal consent for us to undertake the procedure. It's absolutely vital that we also check that we have the correct patient by confirming their name and date of birth verbally, along with a hospital number on the name band. This may seem like overkill, but mistakes do happen all too frequently, and we should do as much as practically possible to eliminate the risk. I always check which is the patient's non-dominant hand and use that if I possibly can, as it's more convenient for the patient and reduces the chance of the cannula getting pulled out accidentally as the patient moves around. For routine cannulas, as opposed to emergencies, we usually insert as distally as possible, using the veins in the dorsum of the hand first. And the rationale for this is that we can then continue to move more proximally to the cephalic vein or antecubital fossa if we need to change cannulas. Wash your hands and inspect your proposed site. Do they look like and feel like good veins? You can temporarily occlude the vein proximally to see how it feels to give you a better indication of the suitability of the vein. Once you've selected your vein, go to the preparation area and prep your kit. Gather the equipment that you're going to need. A tray to put everything in, referred to as the ANTT tray, something to clean the tray with, a cannula of an appropriate size, I usually take a couple in case I miss, a cannula dressing, something to clean the skin with, a Chloropret Frep, which is a chlorhexidine based wipe, some gauze, which is useful for mopping up blood in the remote chance of messing things up, a saline flush, and you'll need to check this with somebody first before delivering it to your patient. A syringe to draw the flush up with, and a needle to draw that up with as well. Now, whilst on the subject of this, you will see people drawing the flush up directly using the syringe with no needle on the end of it, like you can see on the screen now. This is actually considered poor practice and therefore shouldn't be done. Then you'll need a second needle or needleless bung, which is what we're going to use in this case, a disposable tourniquet, a sharp spin, an apron, and a couple of pairs of disposable non-sterile gloves. You'll also need an appropriate trolley to put everything on. So begin by washing your hands using the 7-step process that you see Faye doing here. Wash the trolley that you're going to use thoroughly with the sandy cloths. And then clean your tray. If it's visibly dirty, use soap and water. Clean the ANTT tray thoroughly, including the inside of it, the edges of it, and the bottom of it. Since you've been cleaning, then it's probably a good idea to wash your hands again using the 7-step process. We've abbreviated this a little bit here to save some time. Open your equipment into the tray, taking care to ensure that the key parts do not come into contact with anything and remain covered. We used to drop them into the tray itself, but found when people were in a hurry they opened them from a great height and key parts were becoming disconnected and contaminated. So it was felt that it was better to actually take them out by hand. And whilst this is less than ideal, it's safe for the majority. As I said before, the key parts of the cannula are already covered and therefore protected. However, in the case of the needle and syringe, once they're open, the key parts are exposed. Therefore, it's important that before placing them both into the tray, they're connected up, and that will protect their key parts. Equipment still in its packaging, and extra stuff such as tourniquets and gloves should be placed to the side of the ANTT tray rather than placing them in the ANTT tray. Once all your equipment is open in the tray, wash your hands since you've been touching potentially dirty packaging, and then put on a pair of gloves and draw up your flush. Taking the flush out of shot when you do it, we'll do a pickup and then break the top off the saline, unsheath the needle and insert it into the vial at a slight angle, not too far in. Turn it upside down and aspirate back on the plunger. Once the flush has been drawn up, remove the needle from the end, placed in the sharps bin. You've now got your key part of your syringe exposed, so be careful with it. Take your octopus and attach the syringe to the end of the octopus and flush both ports with saline. Now it's really important that you do this, otherwise you'll leave air in the octopus which will be flushed into the patient's circulation, and air doesn't mix well when introduced that way into your patient. Leave it connected.
So I'm just going to...
When you get to the patient's bedside, wash your hands again as you've been walking through doors and touching things. Apply the tourniquet about a hand's breadth above your proposed insertion site, allowing the vein to fill by occluding venous return. Nice visible bouncy veins are the best. Once you're happy with your site, release the tourniquet, otherwise it's going to get a little bit painful for the patient if you leave it on too long. Wash your hands and put on your gloves. Some people will do this after cleaning the site, but I don't feel it matters too much. Break the ChloraPrep wipe by squeezing the wings together. You'll hear a crack, and then shake it up and down to soak the sponge. Clean the site thoroughly using a scrubbing motion as recommended by the manufacturers for 30 seconds. Yes, 30 seconds, and that seems like a long time. A very long time. A really, really long time. And then leave it to dry for 30 seconds. During this 30 seconds, you can reapply the tourniquet. Take your cannula, fold out the wings and remove the sheath, and then hold it in such a way that your fingers cannot touch the key parts, with your thumb resting behind the cannula. Tether the skin with your non-dominant hand, not too taut, and the idea of this is to stop the veins moving around as you press the cannula needle against them. Place the tip of the cannula at the insertion point, hold it at an angle of about 30 degrees to the skin, and then advance the cannula so that it pierces the skin and enters the vein. As it enters the vein, you should see the primary flashback. Withdraw the needle back from inside the cannula slightly and look for the secondary flashback. Hold the cannula, keeping the needle where it is, push the cannula in one smooth motion into the vein, but now release the tourniquet. You can place a piece of gauze under the cannula to catch any spills that might happen as you remove the needle. Place the thumb or a finger on the vein at the tip of the cannula to stop blood from leaking out as you remove the needle, and place it straight into the sharp spin. Take the octopus, being careful not to touch the key parts, and remove the protective cap off the end, and then connect the octopus to the cannula. Flush the cannula, warn the patient that it might feel a little bit cold, and inject a few mils of saline. There may be a little resistance at first, but then it should flow smoothly with no telltale bubble of failure appearing under the skin, indicating that we're in tissue rather than in the vein. All dressings differ slightly, and it's best to be shown by a person how to put them on. The area should be wiped with spilt blood and dried before you do that, and the cannula should be secured with a clear bit of the dressing over the insertion site so that it can be inspected for signs of infection.
Well done. Okay.
So that's it, the principles of cannulation. Go practice in the skills lab, come to one of our sessions and have a go, practice on each other, practice on the models, and then go off onto the wards and under strict supervision, practice on patients. You'll find it very, very different. Any questions, please use the blog or contact myself or one of the skills team in person. And good luck.